Okay.
So xiphisternum to the
Medial.
Can you use umbilicus?
No.
Can, but we always prefer xiphisternum because of bony landmark. Books will tell you umbilicus because umbilicus varies with individuals, right? So how will you measure? So you first use you have centimeter range and inch. So from xiphisternum to medial. So first, before you even do that, take a marker or an eyeliner and mark at the xiphisternum, mark at the malleolus. So you use only a single standard point at the malleolus. You're going to do this bilaterally also. Let's say you mark here and mark here. So use in inch first. Measure, okay. Then you convert it to centimeters. Okay, and read the centimeter reading. And do this 3 times. 1, 2, 3, and get the average. That's what you do for apparent limb length. Can you measure on both sides? Now you go to true limb length. True limb length means to see if there's actually any actual shortening of the lower limb. Okay, so how will you do true limb length? First, square the pelvis. So what do we mean by squaring the pelvis? To make sure that the ASIS is in line, in parallel. So sometimes you can use this measuring tape, not to measure, but to just to ensure that they are on the same line. Okay. So you adjust and see if it's on the same, ASIS is on the same line. So this line represented by the tape must be perpendicular with the lower limb. So you must get 90 degrees here. Once you have confirmed that the pelvis has been squared, what are the landmarks you take? ASIS to medial malleolus. Okay, then you change, same thing, you do 3 times and get the average. Now let's say there is limb length discrepancy. Let's say there is a true limb length discrepancy. How will you know if the limb length discrepancy, the shortening is due to femur or tibia? Segmental. So one is segmental. So how will you do segmental measurement? So for medial joiner. So you have to bring back a bit of knee examination. How do you mark the joint line? So this is fibrosity. Then as I go up, this is patella tendon. This is the soft region is the joint line. So I put a mark on the medial joint line. Medial joint line. I put a mark. So segmental means from ASI, the femur length is taken by ASIS to the medial joint line. Tibia length is by the medial malleolus and medial joint line. That's segmental measurement. But let's say they request for a special test to know whether the shortening is due to femur or tibia, then what do you do? Galeazzi. So how will you do Galeazzi? So you flex about 90 degrees. But before you do Galeazzi, you must also make sure that the pelvis is square. Squaring of the pelvis is done. Okay, ASIS, you square the pelvis. Then Galeazzi test, okay, you have to make sure the pelvis is square, then you flex. Okay, then after that, you make sure that the heel is on the same level. Then you just put your hand on 2 locations, distal thigh, proximal leg. Okay, so let's say the heel is on the same level, assuming that, and this is what you get. When you put the hand on the distal thigh, you get a gap here. So it means that this right limb is shorter due to tibia. If the shortening is on the thigh, it is due to tibia. And let's say, given the same scenario, the heel is on the same level and there's a shortening here. There's a shortening here. So when you put your hand on the proximal leg, there's a gap here. So this limb is shortened due to femur. Okay. So that's Galeazzi test or Ellis test. Let's say there's a femur shortening. You want to do Bryan's triangle. What's the purpose of Bryan's triangle? You want to see if the femur is shortened because of a supratrochanteric shortening or infratrochanteric shortening. That's the gun. Flex, I show like where you give it anatomy and you share to your flex. So you want to Bryan's triangle is to know whether so this is greater trochanteric, lesser trochanteric, intertrochanteric line. You want to know if the pathology, the shortening of the femur is due to a supratrochanteric cause or infratrochanteric. So the Bryan's triangle will help you tell that. So how do you measure the Bryan's triangle?
The line to measuring line to
Hmm.
Then greater trochanter to
To the
yes.
yeah. So let's see you palpate the ASIS. ASIS is here. Okay. From here you draw one line down to the base of the bed. Okay. Another line you palpate the greater trochanter. Okay. So when you palpate the greater trochanter, rotate. Okay. You rotate the so Brine's triangle ASIS. From the ASIS you draw one linear line down to the base of the bed. Okay. The other line, so you palpate for the greater trochanter. Okay, when you palpate, you get a hard bony prominence here. You rotate, and you can feel. That's how you confirm the greater trochanter. When you rotate, you can feel it. Okay. So from the greater trochanter to the ASIS, you draw another line. Okay, so you have one linear line here, one linear line here. So the third line, horizontal line, will complete the triangle. This is the Brian's triangle. That's the length. So take this length, compare it with the other limb.
1.
So if there's shortening, let's say I get, so this is, okay, I think I can show here. So, wait, why am I doing that? Show here. Okay. So let's say, this is what we say, it's alright. So where's the Brian's triangle? Greater trochanter, ASIS. So from down, ASIS down, one line, okay, and from the greater trochanter to the ASIS. So you have one line here, and this will complete a triangle. So this length you compare bilaterally. If it's shorter, if there's a reduced dimension, it means that the shortening is due to a supratrochanteric shortening. Supratrochanteric shortening. Okay, that's what it means. So you can see the sequence. First, you check for the limb length. Then you know whether the shortening is due to tibia and femur or femur. If it's due to femur, you go more specific and know if it's whether it's supratrochanteric or infratrochanteric. Okay. Look, feel, then movement to each foot. So what are the movement of the hip joint?
Flexion, extension, abduction, internal rotation, external rotation.
So flexion will be, how will you describe the patient? Patient-friendly words. Angkat kaki, angkat kaki, angkat kaki means it's also angkat kaki. It's also angkat kaki. Bengkok kaki means it's also bengkok kaki. Bengkok kaki. Knee to shoulder, easy. Bring your knee as close as possible to your shoulder. This is flexion. Okay. Then you check for, yeah. So flexion means where do you get the goniometer? So where's the goniometer? Someone do.
Okay.
So hip flexion, what will be the patient-friendly word?
Bring your knee to the chest.
Knee as close as possible to your chest. Okay, do it. Okay. So how will you do the goniometer? Okay, yes. Okay. What's the angle?
110.
Okay, more. You can do more. Okay. If active and passive, so ask active first, then you do passive. Okay.
130.
So what's the normal range of hip flexion?
0 to 130.
130. Okay. Extension means you ask the patient to lie on his lateral side. Okay. Same thing. You look at hip, right? So it doesn't matter if the knee is flexed. So same thing. You put in a neutral position. Then according to the movement, you just give the movement. So normal extension should be
0 to 20.
20. Okay. Okay. And make sure the patient is comfortable. Okay. You palpate at the ASIS and you extend. Okay. Like this. This must be straight, controlled. So use the line on the pants very easy. Okay. No, you must be on the straight line. Okay. Then 1, 2. Yes. Okay. Okay. It's about this much. Okay.
So 20.
Okay, 20. Then what else do you have? Abduction and adduction. So abduction and adduction, you must square the pelvis. So before abduction and adduction, very important to square the pelvis. Okay, abduction, adduction. So how will you do abduction? Abduction, always palpate the contralateral ASIS. Palpate that and then you slowly abduct. So normal abduction is, like imagine. Same thing, one wing will be here, the other wing just moves along the plane of motion. Okay. Oh, you have done that. You have done. Okay. We must palpate on the contralateral. Okay. So from neutral position, you just okay. So it is about 55 here. Okay. What's the normal angle?
45.
Okay, so it's 55. Okay, here. Adduction will be same thing. You hold here and you just move. Okay, so again try to measure. So what's the normal adduction angle?
0 to 20.
20. Right. Okay. 1, 2, 3. Okay. 20. Then what are the movement? Internal rotation, external rotation. So internal rotation, you just flex the knee. Then this is external rotation. This is internal rotation. So put one wing here and see the movement along, and the other for internal, see the other way. Okay. Okay. So this will be external rotation. Yes. Okay. What's the angle? 65. Okay. What external rotation? What's the normal angle?
Is it 20?
External.
20.
No, it's the other way around. What's the?
50.
Okay, 50. Okay. Internal rotation will be
20.
20. Yeah. Correct. So you just do all this movement. Important because in osteoarthrosis it will be restricted range of movement will be there. Okay, so to sometimes rule out other causes like maybe you don't know it's spine or this one. Okay, one thing of course neurovascular examination will tell you, neurological examination will tell you. Another thing is if there's restricted range of movement over the hip joint, it is more suggestive of intra-articular pathology. And after that, what do? Movement is done, look, feel, move is done.
Special test.
Special test. Thomas test we did, haven't we? Okay, so Thomas test will be done. So Thomas test you can do it along with movement. Actually, once you flex, you can directly do Thomas test. So what do you understand by Thomas test? So Thomas.
Yes, flexion.
So yeah, so flex the hip. So sometimes the hip will be permanently flexed. Hip means the femur. That's why the femur is permanently flexed. You cannot flatten it. So let's say due to some hip pathology, it's the thigh equates to femur. The femur is permanently flexed like this. They cannot push it down. What can be the cause? A lot of causes, but you have to think about avascular necrosis leading to osteonecrosis and osteoarthritis or osteoarthrosis. So what are the causes for avascular necrosis?
Fracture of neck.
Okay, yeah, fracture of neck or femur, yes. Okay. You can think about pancreatitis, lupus, alcohol, steroids, trauma neck or femur fracture, and infection, septic arthritis, osteomyelitis, can be idiopathic. Okay, idiopathic can be there, then Caisson disease or decompression sickness. Okay, collagen vascular disease can be there.
Gotcha.
Gotch's disease, then amyloid disease, sickle cell disease, what else? Radiation, okay, all these can be a cause. Steroids, okay, as I said, it can be a cause. So all this can reduce the vascularity. So what happens is, what supplies the head of the femur? Circumflex, okay, median circumflex artery. So sometimes when there's less, okay, microvascular occlusion, for example, sickle cell disease, micro occlusion is there, steroid usage will be there, okay, smoking possibly, okay, and trauma, when you get neck or femur fracture, you obliterate the blood vessel to the head, so the head will undergo necrosis, and that can cause osteonecrosis, which will cause permanent flexion of the hip. But when you see the patient, you might not be able to catch the point, because what happens is they will mask. So let's say your hip is flexed. So you can actually make your hip look like it's normal by giving an excessive lumbar lordosis. So when you give a lordosis, the space here will be compromised and it will look like you can mask yourself and show like as if the posture can change to show like you're having a normal hip. So they will get an excessive lumbar lordosis. So that is excessive lumbar lordosis will be there. So imagine by compromising this bend, you're straightening the femur. So that's why in inspection it's always important to inspect literally to see if there's any excessive lumbar lordosis. So Thomas test is to confirm that. So the first thing when the patient is lying down, you must make sure that try to even remove the bed. Fully. Your exam will be flat bed also. It won't be your ward bed. You know this, right? You cannot lift and everything. It will be flat. You'll use MO room for the examination, not the ward. Okay, then. Okay, so the first thing is you want to, patient is lying down, you want to rule out lumbar lordosis. So you bend and see if there's any light passing through, excessive light passing through the lumbar spine. Next, you slide your hand at the lumbar spine. So a lumbar spine is normal to have lordosis. Even normal patient, lordosis is normal. Okay, in fixed flexion deformity, they will have excessive lordosis. So it's normal to feel a gap between your hand and the patient's lumbar spine. So let's say this is the affected hip. How will I obliterate the lumbar spine? As I said, the patient will exaggerate the lumbar lordosis, right? So if I flatten the spine, whatever pathologies in the hip will surface. So what's the best way to obliterate the lordosis? It means I want to flatten the spine. How can I do that? Flex the normal hip. So as he flexes, so I bring the knee as close as possible and hold it. And when he does this, I can feel the spine flattening and I can feel the pressure on my hand. I can feel it. That's when I say the lumbar lordosis has been obliterated. It has been, means the spine is flat. When the spine is flat, there's no masking. So if there's an actual fixed flexion deformity, I'll notice it on the pathological hip. Then I'll measure the angle, I'll measure the fixed flexion deformity between here and here. Okay. And also I will try to press. Okay. What if I successfully push this down? What will happen? The lordosis will reappear. I can feel my palmar surface being relieved of that pressure from the lumbar spine. Now, let's say I'm not able to I want to do Thomas test, but the moment I put the patient flat, I can't flatten this. This can be due to a knee fixed flexion deformity or hip. But the idea is I need this to be flat for me to do the Thomas test. So how can I solve this situation? I need the hip to be flat. Yeah, so I basically move it to the side. So when I move it to the side, I get the thigh flat on the bed. So this is called modified Thomas test. Then after that, what other tests do you have? Stinchfield test. Okay. So this is important to differentiate spinal pathology and actual hip pathology. Okay. So you ask the patient to lift the leg. Okay, mid-air, straighten, fully straighten. Okay. Then I will try to push the hip, just like how you're testing for L1 myotome. I'll try to push the hip down. He must resist. Resist. Okay. In case the patient feels pain at the anterior hip, it means it's an intra-articular cause, like OA. If the patient feels the pain posteriorly, it's due to a spinal pathology. It's due to a spine cause. Okay. That's all for hip.